today I'm going to talk about something that I spend a lot of my time dealing with, and that is patients with breast carcinoma who receive neoadjuvant chemotherapy. And specifically, we're going to talk about possibilities to de-escalate that neoadjuvant chemotherapy. I have no disclosures. So I want to talk today about quantifying the response of breast carcinoma to neoadjuvant chemotherapy, how to apply those methods to inter-regimen breast core biopsies, and how using inter-regimen imaging studies and breast core biopsies can be used to identify candidates for a limited course of chemotherapy, or what's called de-escalation. So what are the indications for neoadjuvant chemotherapy? So neoadjuvant, of course, means giving it before resection. And we don't want to give anybody neoadjuvant chemotherapy who doesn't need chemotherapy ever. So in general, these patients have high-grade tumors. They are usually triple negative or HER2 positive. And if they are hormone receptor positive, like ER or PR positive, then they are high-grade and have some indication by other methods like gene expression signatures that show that they are indeed high-risk tumors. So neoadjuvant chemotherapy is beneficial for the patient and for the clinicians. It allows to assess the patient's tumor's response to chemotherapy. It's an in vivo test of the chemotherapy. Well, we want to find out if they have a pathologic complete response or PCR. And if they do, meaning the chemotherapy kills off all of their tumor, then that pathologic complete response or PCR correlates with their survival, both their disease-free survival and their overall survival. And it is now used, the PathCR can be used as a surrogate endpoint in trials of neoadjuvant chemotherapy. It correlates with long-term survival. So since 2014, it's been used as a basis for drug approval by FDA. And whereas neoadjuvant chemotherapy was initially used for patients with large tumors, its use is being expanded. Many patients with small primary tumors will receive neoadjuvant chemotherapy, especially if they are HER2 positive. So what is a pathologic complete response? Well, it is simply, there's no residual invasive carcinoma in the breast or lymphovascular invasion in the breast, and there's no regional lymph node metastases. So that means that you have to evaluate both the breast and the regional lymph nodes, the axillary lymph nodes. And if you find DCIS alone in the breast and no invasive carcinoma, so ductal carcinoma in situ, that alone does not increase the risk of distant relapse. So that is not, if you have DCIS, if you have DCIS alone, that is still a pathologic complete response. If you have disease only in the lymph nodes and no invasive tumor in the breast, that's still quite significant in that the number of lymph nodes involved is inversely related to survival. And also, if you have a patient that's known to have a node positive tumor and you convert that node positive to a node negative tumor with chemotherapy, that will improve the patient's survival, even if there's tumor left in the breast. So invasive carcinoma in the breast and regional lymph node metastases are the things you have to assess to see if there's PCR. And if you don't have PCR, meaning you have some response, but not a complete response, there's multiple methods for quantification of that less than complete response. So I'm just going to mention these kind of for historical interest. The NSABP B18 study was one of the first studies to look at response of carcinoma to neoadjuvant chemotherapy in the breast. And they basically, it's a semi-quantitative method, and they actually evaluate the breast tumor and the lymph node metastases separately. Miller-Payne is exclusively evaluates the cellularity, the change in cellularity from the pre-treatment breast primary to the post-treatment breast primary. We're going to skip the others because those have been used even less, and move on to two methods that are primarily used now. At minimum, if a patient has receives neoadjuvant chemotherapy, you have to say what their pathologic stage is after that neoadjuvant chemotherapy. So you give it the Y prefix. And you have to say how big the tumor is in the breast, the T stage, and the node stage. So the YPTN, that's the standard, very simplified evaluation of response to chemotherapy. And then a little bit more detailed is the RCB system, which we'll talk about in detail. That's the residual cancer burden system. So I will just mention NSABP B18 because it is the study from which we get a lot of information about what tumors look like after they've seen chemotherapy. It was in the late 80s and early 90s, so certainly pre-HER2 testing and HER2 treatment, targeted treatment. This study tested a cohort of patients who received neoadjuvant chemotherapy and compared those to patients who received adjuvant chemotherapy. And the chemotherapy was adriamycin and cyclophosphamide. Sorry. And I just want to mention it because it talks quite a bit about what morphologic changes do you see in tumor cells, not just are they there or not, but when they are there after chemotherapy, what do they look like? Do they look different? And they described bizarre or meganuclei. Very frequently, the tumor cells are histiocytoid. And because they have that histiocytoid look, they actually resemble lobular carcinoma. They also are often have a lot of cytoplasmic vacuolization or have a lot of eosinophilic cytoplasm. They can look a little squamous almost. They will often have a lot of nuclear pleomorphism, kind of almost a degenerative look to the nuclei. And so they may have a very high nuclear pleomorphism score, but their proliferation should be knocked out almost completely. They also will have increased apoptosis. So you really, the Nottingham grade or the tumor grade after neoadjuvant chemotherapy isn't usually that interesting because it's almost always a grade of 2, meaning you get 3 points for tubule formation because it doesn't really form tubules. You get 3 points for nuclear pleomorphism because we have this bizarre nuclei as we described, and you get 1 point for mitotic activity. And so that gives you a score of 7, which is a grade of 2. So that's the usual case. If you do have residual, like significant mitotic activity, that's significant, and that should be commented upon, and that would bump it up to a Nottingham grade of 3 with a score of 8. So whenever I see significant mitotic activity after neoadjuvant chemotherapy, I always mention it because that is a poor prognostic sign. The changes in the tumor cell morphology occur both in the invasive carcinoma and in the DCIS generally. And this is just an example of invasive breast carcinoma after neoadjuvant chemotherapy. There's actually quite a bit of tumor. You can see even at low magnification, these invasive carcinoma cells, and they have very large nuclei, and there's DCIS here and here and here. And when we look up close at the invasive carcinoma, it looks very histiocytoid. You have these very large round cells with the nucleus pushed off to the side and abundant eosinophilic cytoplasm or pale cytoplasm in this case, a lot of cytoplasmic vacuolization. Those are very common changes that are generally not seen before. If they're not seen beforehand, they are seen after neoadjuvant chemotherapy. When the chemotherapy works better, this is the same patient, but in a different part of the tumor, you'll see just a few tumor cells here and here in a background of this kind of collagenized tumor bed. So tumor bed is pretty easy to see, especially if you have tumor cells. Sometimes if you don't have any residual tumor cells, you might be at a loss to say, is there truly tumor bed? Like, did they remove the right part of the breast, basically? One common thing is you'll see stromal collagen or hyalinization like we saw in the last image. The tumor cells that are, if they're there, they will be in a desmoplastic or a fibromyxite stroma, or a lot of times an elastotic stroma. The uninvolved breast tissue, the uninvolved terminal duct lobular units tend to have sclerosis of the basement membrane. They might have a little bit of epitheliotypia, even some marked epitheliotypia, but not a lot of epithelial hyperplasia. And this is what we want to see after neoadjuvant chemotherapy. I liken this to somebody took an eraser. It just looks like they wiped out everything. So we don't see any tumor cells. We see this collagen or kind of elastotic stroma. And we don't even really see benign ducts and acini. So this will be evident grossly as an ill-defined mass or kind of a firm area. And you have to sample it extensively to prove that there's no carcinoma cells in there. Lymph nodes are sometimes a little bit harder to evaluate. If you do have a tumor metastasis that has had response to chemotherapy, you'll see a little bit of a scar around the tumor cells. And again, you might see that fibromyxoid stroma. You might still see a few aggregates of foamy histiocytes, but often you don't. I think the difficult case is when you just have the scar without tumor cells, because you can have kind of a small collagen scar in lymph nodes without ever having had tumor. So sometimes that's hard to define. This is a lymph node metastasis, and you can see these clusters of tumor cells. And you can see they have some of this pink collagen, which you don't typically see in a lymph node. Again, when you see the tumor cells, it's easy to say that's a tumor bed. But if you didn't have the tumor cells and just had this much collagen, it might be a difficult call to make. Here you see a little bit more collagen, and you can see these tumor cells, which if you did a cytokeratin immunostain, you don't have to, it would light up these kind of singly dispersed tumor cells that are very histiocytoid, just like we saw in the breast. But again, all this extra collagen. So the thought is that before she got chemotherapy, there was many like back-to-back tumor cells, and now many of them have died because of the chemotherapy. So the residual cancer burden, to give a score for the residual cancer burden, you need a few basic pieces of information. You need the primary tumor dimensions in the two largest dimensions. You need the cellularity, the area with invasive carcinoma cells in that invasive carcinoma. And you need to know how many lymph nodes are involved and what is the diameter of the largest metastasis. This was developed as a predictor of distant relapse-free survival for patients receiving neoadjuvant chemotherapy, meaning distant metastases. And each variable has prognostic significance. So they developed the RCB using this cohort of patients. This was published in 2007. It was kind of in the late 90s, early 2000s, and it was before maybe at the beginning of HER2 testing, but before HER2 targeted therapy was ubiquitous. And this is what they got. They got paclitaxel and this FAC regimen. And they looked at all those patients, and they knew their outcomes, and they developed this formula based on that. And then they applied that to a different cohort of patients. So this is like a Kaplan-Meier curve, but just for distant relapse. And you can see the RCB 0, meaning a path CR, is the gray line. And the RCB 1 is the kind of the reddish line. So they're pretty close to each other. And when you get down to the RCB 2, you have more distant relapses. And of course, RCB 3 is even more. So you might say, well, that's just because it was a higher stage. But in fact, if you look at the stage 2 and stage 3 to 4 patients, you can say, so of all this image B, these are all patients that are stage 2 by standard TNM staging. But they have quite different relapse rates based on what their RCB score is. So the lower the RCB score, the better for them. So RCB 1, again, is close to no relapses, and RCB 3 is quite frequent relapses. And when you get to stage 3 and 4, you also see kind of it splits out between RCB 2 and RCB 3. For stage 1, it's not as interesting or not as significant because they're all kind of clustered together and they all have RCB 1 and RCB 2, and there's not a significant difference between them. After that, they actually tested many more patients for a total of almost 1,200 patients. And they found basically the same findings, that the RCB index and classes were prognostic in all treatment cohorts and phenotypic subtypes, and especially in these stage 2 and stage 3 tumors after neoadjuvant chemotherapy, the RCB adds more information for the clinical team. And so, for instance, this is, stage 1, stage 2, and stage 3. So again, stage 1, it's not much difference between RCB 1 and 2, but when you get into stage 2, you do see a significant difference between RCB 1, 2, and 3, and stage 3, you see a significant difference between RCB 2 and RCB 3. So I've talked to especially the house staff several times about sampling of tumor bed, and I won't go into detail here, except to say that it can be challenging, especially if you have an ill-defined tumor, or you're really having trouble finding a tumor grossly. And they started off with a very large tumor, and you're trying to find any small bit of residual invasive carcinoma. If you have a large tumor bed, usually the biopsy marker, the radiopaque biopsy marker, is near the middle of the tumor bed, and that's usually where residual invasive carcinoma will live, but not always by any means. Sometimes you have to go well beyond that core biopsy marker. So this is just another example of a treated tumor. Again, you can see it kind of has this variable cellularity in this part. In the lower part of the screen, it's kind of a low cellularity. And then at the periphery, you actually have more cellularity in this, and this is all invasive carcinoma. When you look at high magnification, more cellular areas, again, you see these kind of histiocytoid tumor cells. They're not forming tubules at all. They have very large nuclei, quite a bit of nuclear pleomorphism, but not much mitotic activity. So in this case, even though there's quite a few tumor cells, it seems like the chemotherapy has done something. And here in this part, you see the same tumor where it's quite paucicellular, and you can pick out the tumor cells because they have those quite dark nuclei. But they can sometimes mimic plasma cells if they're not as big, or histiocytes. You do have to be a little bit careful about measuring the correct size. So you really want to know how big is how far do the invasive carcinoma cells stretch. And you have to really correlate your gross findings from with your microscopic findings. And for instance, here, this is the kind of pink area. In all these cases, the pink area is what seemed abnormal grossly, and the blue area is where there's actually invasive carcinoma. So you only measure where you have the invasive carcinoma. Sometimes that's smaller than what you thought grossly, and sometimes it's a bit bigger, or even a lot bigger than what you thought grossly. And I will just make this one. I think this is where people get into trouble. If you have a tumor bed, if you have a patient who had a known, 3 or 4 or 5 centimeter tumor, and they get neoadjuvant chemotherapy and it works quite well, but not completely, it does not always have an even response throughout the tumor. And so you might have clusters of tumor cells in this larger tumor bed. I think the most accurate way to measure this tumor is to measure from invasive tumor cell to invasive tumor cell in the 2 largest dimensions. But then you have to average out the cellularity. So you have these 3 areas where the cellularity is significant, and then you have other areas that you have to average out, which don't have any tumor cells in them. People often ask, whenever people have seen a lot of these cases, they wonder about some cases where it seems like the only tumor in the breast is tumor in lymphovascular spaces. That can be a challenge. I actually have never seen, I always get asked that question. I don't think I've ever seen that happen. But really, if you think about it, the LVI is kind of clustered in a certain area, you can still estimate, you can just treat those tumor emboli as invasive carcinoma cells and average that cellularity in those lymphovascular spaces with the stroma around it that is not involved. If you have LVI that's widely dispersed throughout the breast, that makes it more of a challenge. Usually you'll have a lymph node metastasis as well. In that case, and lymph node metastases in the RCB calculation really bump up that number. So the tumor in lymph nodes won't make a huge difference. If you do have just a little bit of tumor in the lymph nodes in regular breast pathology without neoadjuvant chemotherapy, we talk about isolated tumor cells, meaning less than 0.2 millimeters or fewer than 200 cells as not being significant. That is not the case in neoadjuvant chemotherapy cases. If you have any residual tumor, even if it would normally be classified as isolated tumor cells, that is not a complete response, and it is a significant finding that you have to record. As I said before, sometimes it is quite hard to say how much or how big the metastases are. But if you have fibrosis between the tumor cells and a lymph node, I would include the whole area involved by tumor cells. I'll just mention this briefly. So this is a calculator if you wanted to figure out what somebody's residual cancer burden is. You can use the formula that I presented before, and actually I've seen pathologists, the Abbott pathologists do that. They have the formula built into their synoptic, but I've always found it just as easy to use the website. But just remember, what really they want is estimate of how many invasive tumor cells there are in the breast and how many metastatic tumor cells there are in the lymph nodes. And they ask you about DCIS. But the only reason they ask you about DCIS is so that they can subtract it out if it's there. So in this hypothetical case, the tumor is 22 by 15 millimeters. The total tumor cellularity in the breast is 20% in that 22 by 15 millimeters, but half of that is DCIS. And there's 3 positive lymph nodes, and the largest metastasis is 2.1 millimeters. It gives you an RCB of 2.858. So if you just imagine that DCIS wasn't there, you get a cellularity that's half as much, 10% overall, and just say there's no DCIS, you get the same exact RCB. So I include all that information in my pathology report. The tumor size in the 2 largest dimensions, the invasive carcinoma cellularity, and the percentage of the total tumor cellularity, that is carcinoma in situ, the number of lymph node metastases, and the size of the largest metastases. CAP doesn't say that you have to report an RCB. I think every medical center that I worked in for the past 10 years or more has expected it. And I think if you don't record it now, you'll get a phone call, at least at this center. And the residual cancer burden is really not, they're not saying like, oh, you have this much tumor and now you have that much tumor. It's really how much tumor is in the breast right now and how much is in the lymph nodes. So it doesn't consider where you started, it just considers what you have now. I will say that if you, obviously these patients all have biomarkers done on the diagnostic core biopsy. You have a very low threshold for repeating those, especially if those are at all negative. A HER2 negative tumor, if you find HER2 expression in the resection, that's going to change the patient's treatment drastically. Similarly, if you have an ER/PR negative tumor, if the resection shows some areas that might be lower grade, you might suspect are ER positive, I would repeat that testing on the resection because that will change the management to some extent in that they'll receive adjuvant endocrine therapy. So on to the I-SPY trial. So the I-SPY trial is a multi-center trial, and you can find out all you want to know about it at their website. It has this acronym for a name which is a little bit convoluted, but it's basically trying to individualize neoadjuvant chemotherapy for patients with locally advanced breast cancer. These are the institutions that are involved with it. It's about 20. We are one of them. We're not the biggest institution as far as case load in general, but we do contribute a lot of cases to this study. Our medical oncologists recruit patients for this study very frequently. So it started out with I-SPY 1, which was from 2002 to 2006. And this was really, they were just trying to decide what is going to be different about this study? How are they going to monitor these patients? What kind of molecular testing do they need? What kind of standard immunochemistry? What kind of imaging? And so they basically had this cohort of patients, 210 patients, who received neoadjuvant chemotherapy. This was kind of right. So easy to remember that HER2 started to be tested for and then treated in the early 2000s. And so some of these patients that were HER2 positive were tested and found to be HER2 positive. Some of those patients received HER2 targeted therapy, trastuzumab, but not all did because it wasn't actually approved for neoadjuvant use until 2005. These were not, this is a little bit different than the I-SPY that we have today in that they were not all high risk. They're mostly high risk by mammoprint, but not all. And 90% were intermediate or high grade, 91% were high risk by mammoprint. They did Ki-67 on all of them. And if they felt it was high, meaning more than 25%, that was associated with an increased responsive to neoadjuvant chemotherapy in the HER2 negative tumors. So it's these ER positive tumors are the ones that are challenging sometimes to treat with neoadjuvant chemotherapy. And if they have other high risk factors about them, then they are more likely to respond. So if they're very proliferative, as measured by Ki-67 or mammoprint, then that suggests that they're going to be more likely to respond to neoadjuvant chemotherapy than a lower grade, lower proliferation tumor. And you can look at their PCR, it's not super great. 27% taking all comers. If you have your hormone receptor positive HER2 negative, that was quite low at 9%. The highest was the HER2 positive hormone receptor negative, 45%. And then the triple positive and triple negative are kind of in between at 33 to 35%. Notably, these calculations for the HER2 positive patients were patients that did not receive neoadjuvant trastuzumab. And this is just that pictorially. For instance, here is this hormone receptor negative, HER2 negative, so triple negative tumors. If they had a path CR, then that's the yellow line, and they have they have a good recurrence-free survival. And if they did not have a path CR, that dropped off quite significantly. That finding was true as well in HER2 positive patients, even though they didn't receive neoadjuvant trastuzumab, and maybe not as striking as your hormone receptor positive HER2 negative tumors. So that was kind of the pilot, and to see how this would work and how this patient would be monitored. So I-SPY 2 launched in 2010. So they specified that the breast carcinoma had to be at least 2.5 centimeters in longest diameter. That actually, often that's a palpable mass, but also can be by imaging studies. And if it is by imaging studies, it can include DCIS in the breast, but certainly they have to have invasive carcinoma as well. So these are all high-risk tumors. Again, remember, we don't want to give neoadjuvant chemotherapy to someone that really is not a good candidate for chemotherapy in general. So patients who are HER2 positive or triple negative are, in general, good candidates for neoadjuvant chemotherapy. And the ER positive, HER2 negative patients are candidates if they are high risk by mammoprint. They have, I-SPY 2 has a control arm of paclitaxel followed by adriamycin and cyclophosphamide, AC. That's their control arm. And then if it's a HER2 positive patient, they receive HER2 targeted therapy. Initially, it was just trastuzumab, then it was trastuzumab and pertuzumab. And then the patients on the study arm receive new agents. And the new agents, depending how the individual patients respond, are either graduated or they're discontinued. And the primary endpoint we're looking for is a path CR, but and because that is a surrogate marker of recurrence-free survival and overall survival, but not of course, not everyone has a path CR. So when they don't have a path CR, then we measure the residual cancer burden. This is adaptive randomization. I'll talk a little bit, very little bit about that. And ultimately, goal was to also measure disease-free and overall survival at 10 years. So this is their diagram for adaptive randomization. So basically, patients, depending on their tumor characteristics, are randomized to an experimental arm or control arm. They have an outcome, whether it's path CR or an RCB of 1, 2, or 3. They incorporate that information into the database, and after many patients come through, they decide whether that the experimental treatment is good or bad. So if it seems to be effective, meaning likely to be better than the control arm in a phase 3 trial, then it graduates. If not, then it's terminated. So here's a pictogram of that algorithm. So the patient, when they're diagnosed, they get, certainly they get a core biopsy for diagnosis. They also get blood drawn. They get an MRI. The MRI is, they have, just like we have to do, special evaluation of our pathology findings, the radiologists have an algorithm they have to follow to measure different characteristics of the tumor by MRI. And based on the hormone receptor status, the HER2 status, and the mammoprint, now the mammoprint, they're all going to be high risk. They've actually split it into ultra high and high. So that's a unique division in I-SPY. And based on that, they're assigned a general tumor subtype. And that tumor is randomized such that the study knows what other tumors similar to that did in response to different agents. And that helps them decide which study arm to put them in. So the control arm, again, is paclitaxel, a taxane for 12 cycles, and then AC, so an anthracycline plus cyclophosphamide for 4 cycles. And then there are several experimental arms. So here we just have 2 depicted, where on top of that control regimen, they give something else. And there are many different agents that they've looked at, and we'll look at those a little bit in a few minutes. So after they receive the first 12 weeks of chemotherapy, which in the control arm is just paclitaxel, and in the experimental arm includes another agent, they get another MRI, they get another core biopsy, and they get more blood drawn. And the blood draws are, for circulating tumor cells, et cetera. But the biopsy, in 2017, they started doing this biopsy and collecting both frozen tissue and formalin fixed tissue and kind of pooling those specimens. And that's what we're going to talk about in a little bit. And then the MRI, they gather data about that to see, which MRI characteristics indicate that the tumor might be responding. Then they get their AC chemotherapy, and then they get another MRI, it's more blood drawn. And then when they get the tumor resected, of course, we have to calculate the RCB. So basically, the study is designed to learn over time which tumor profiles predict response to each drug. So if a drug does well within a specific molecular signature, the next patient that comes through with a similar molecular signature will be preferentially assigned to that arm, and that drug will progress through the trial more rapidly. And so they have this Bayesian predictive probability of when they figure out that this drug is likely to be successful in a phase 3 trial, that's when it's graduated. And they say it's graduated, and then it can be used in a different study in a larger phase 3 trial. And they add a new agent to the I-SPY in its place. So if you take I-SPY 2, the first kind of big study of the outcomes was published in 2020, and that was at least 3 years of follow-up. If you take that information, look at who had a path CR, if you take all patients in both control and investigational arms, it was 35%. The best was in the HER2 positive hormone receptor negative arm at 68%. And the triple negative was 42%. The kind of triple positive, hormone receptor positive, HER2 positive is 40%. And as we always know, that the hormone receptor positive, HER2 negative is usually the hardest to get a path CR, and that was true here at 17%. So that's taking all the control and investigational cases together. The control arms you can see are much smaller, right? Because you just have one control arm for multiple experimental agents. But in general, even though we don't have the specific investigational arms listed, you can see that, for instance, the HER2 positive cases, 68% for all patients in that in the control and investigational arm. So because the control arm was only 42%, you know, the investigational agent did better than the control arm. And that was true. They're quite similar in the HR positive, the hormone receptor positive, HER2 negative, but in these bottom three, the experimental arm was beneficial over and above the control arm. And so this is kind of that same this is that same study. So we looked at the path CR. Here we have it again in this table, talking about the path CR rates for the different tumor types. And again, these are for the control and experimental arms together. And we can see here, when we look at the distant recurrence-free survival at 3 years, that those that had a path CR, so those that were achieved, the 35% that had a path CR, no matter how they got it, did better than those that did not have a path CR. So that's just the dichotomy, yes, path CR, no path CR. This is again by tumor type, a little bit more detail. And you can see again that for instance, the triple negative, the HER2 positive, but the hormone receptor negative have quite a wide difference between patients who had a path CR and those that did not. So again, just we suspected this from previous studies, but it's good to reiterate that that is the case. That if you get a path CR, the patients do better. This is I said we would talk about the different agents, and I will briefly this is a list of agents as of, I think, September that have gone through the I-SPY trial. And if they're in this kind of purple color, they've graduated. And the kind of greenish, darkish green color, they're still in progress. Those are up here that have started more recently. And some just were halted and didn't work. So some that did work. So volaparib, which is a PARP inhibitor plus carboplatin, worked. Pertuzumab was just for HER2 positive tumors in addition to trastuzumab, and that worked. And because of that, everybody that has HER2 positive tumors in I-SPY gets both hertuzumab and pertuzumab. TDM1 is an antibody drug conjugate that we'll talk about in a minute, which is basically Herceptin plus a conjugate chemotherapeutic agent plus pertuzumab. That also worked. Pembrolizumab, checkpoint inhibitor, that worked. So these all work. They didn't work in every tumor type, but they worked in some tumor types. And I just want to mention, because this changed quite a bit what we do for evaluating HER2 expression in our I-SPY patients, I want to talk briefly about antibody drug conjugates. And just that they are, here's 3 examples. TDM1 is one, as I said, we've already used in I-SPY and it's already graduated. And that was for HER2 positive patients. And then this SID 985 is in active treatment arm now. This is for, this has also the antibody is trastuzumab. For all these, the antibody is trastuzumab, but the antibody is just binding to the HER2 receptor and helping, in this case, the payload, the chemotherapeutic agent, get into the cell, the tumor cells, and it helps it work more effectively. And you don't need, for some of these, like SID985, the theory is that you don't need a lot of HER2 expression. You just need some HER2 expression to help get it into the cell. And so now, if we have a HER2 tumor that is not amplified by FISH, before the patient can be randomized in I-SPY, we need to know what is its immunochemistry result. So we have to do immunochemistry for all these patients, need both immunochemistry and FISH. So let's move on to de-escalation of care and what's going on with I-SPY and de-escalation care. So thinking about neoadjuvant chemotherapy, the whole idea behind it initially was to de-escalate care, in that these patients who had locally advanced tumors, you're trying to possibly get them from a mastectomy to a lumpectomy. Also, if they had clinically evident lymph nodes, positive lymph nodes, the usual treatment for that would be to do a full lymph node dissection. But if you can treat that effectively with neoadjuvant chemotherapy, you can often get them down to a sentinel lymph node biopsy, which is much less morbid. But we are hoping also to find patients possibly that only need 12 weeks of chemotherapy. So how do we figure that out? Well, we have the serial MRIs and also the core biopsy, which they started to do at 12 weeks in about 2017. And the core biopsy is done obviously with radiologic guidance in the area that's most suspicious for invasive carcinoma. And we're trying to do kind of like a mini assessment of a path. Is there a path CR there or not? If the patient has a 12-week MRI that is reassuring for a good response, and also the core biopsy shows no residual invasive carcinoma, then that patient may now avoid the adriamycin and cyclophosphamide. And just remember that adriamycin has a significant potential for significant cardiotoxicity. There is precedent for this in prior adjuvant chemotherapy trials for colon carcinoma and breast carcinoma, like the adjuvant paclitaxel and trastuzumab only trial for early stage HER2 positive breast carcinoma. Also, there are some studies for relatively short courses of neoadjuvant chemotherapy for smaller breast carcinomas. This is a little unique in that we're looking at these patients with larger tumors. And certainly this is a priority of the I-SPY team, including patient advocates on the team. So again, this is the schematic for the I-SPY trial. And just remember, this is our 12-week biopsy that we're talking about. We looked at the first 40 consecutive core biopsies done at 12 weeks. And then looked at a second cohort of 100 patients, the next 100 patients. And these were reviewed by the pathologists in the pathologist working group for I-SPY, which I'm a member. And so they had digital images of SNAP frozen and formalin fixed paraffin embedded tissue cores. And the pilot study involved 4 pathologists, and the 100 patient cohort involved 11 pathologists. And so we really tried to come to a consensus of whether or not we could decide whether there was a path CR, or at least what we had in the core biopsy had no residual tumor in it. Obviously, we're not evaluating the lymph nodes. The lymph nodes are evaluated by MRI, but not by core biopsy at 12 weeks. So we're just looking at tumor in the breast. To say this is challenging is quite an understatement. The frozen tissue had the problems that one often sees in frozen tissue, that the histology wasn't great. The formalin fixed paraffin embedded tissue was often fragmented, or at least seemed that it wasn't embedded perfectly, so that you just got bits and pieces of each core instead of getting a full face of each core. The 40 case pilot, we didn't have an option for immunochemistry. We did do very limited immunochemistry on the 100 case cohort only for select cases, and we could only do it on the formalin fixed tissue, not on the frozen tissue. It was done at the UCSF research lab. The 11 pathologists in the 100 case cohort actually made made it more challenging to interpret the results rather than less challenging. There was quite a bit of inter-observer variability. And again, these are all pathologists who do this for a living, so it just was challenging. We did the 100 case cohort. We decided that there were just some cases where it was just too hard to tell what was going on. We couldn't definitively say whether there was a few residual tumor cells or not in some cases, whether those like rare, strange looking cells were actually histiocytes or whether there were tumor cells. And we couldn't tell in some cases whether there were kind of round clusters of invasive carcinoma cells or ducts involved by DCIS. So we did some cytokeratin stains for looking at the rare tumor cells, some P63 stains trying to find myoepithelial cells. And then we looked at those cases where multiple pathologists had trouble interpreting them with the H&E alone, and we did come up with a consensus in those cases. I think this data is, as I said, this data here is from in combination with the radiology data, but it does show, so IC negative means there's no invasive carcinoma in the 12-week biopsy. IC positive means there is invasive carcinoma. This just shows the distribution of tumor types. So as you might expect, the hormone receptor positive patients were more likely to have invasive carcinoma at 12 weeks. And for those that did not have invasive carcinoma, they had a higher proportion of triple negative and HER2 positive, hormone receptor negative tumors. These box plots are a little bit challenging. I think they're not super intuitive, but basically if you look at it, so this heading is invasive carcinoma, invasive cells in 12-week biopsy. So IC minus means no invasive carcinoma cells, and IC plus means yes, they're invasive carcinoma cells. And here, if you look at the IC minus, so this means that when we looked at 12 weeks, 25 of these cases, we looked at these at 12 weeks and none of the patients in this column had appreciable invasive carcinoma cells at 12 weeks. When you look at resection, how many had true PCR? Well, 25 had true PCR and 6 did not. So it wasn't, you might think, well, even if they, why do they have invasive carcinoma there after they got even more chemotherapy between the 12-week point and the resection? It doesn't quite make sense, but it was true that we were not able to pick up identify correctly all the patients that would or would not have a path CR. And in fact, if you look at all of the pathologists together, this looks at kind of the positive predictive value and the sensitivity depending on how many pathologists we're talking about. So if they looked at one pathologist, there's the positive predictive value with just one pathologist isn't great. And it gets better, significantly better at 2, 3, 4, et cetera, pathologists, but it plateaus quite quickly, the positive predictive value. As you get more pathologists in it, you can just imagine there's always going to be one pathologist who says, oh, I'm not sure. I think there is some invasive cancer. I'm going to say there's some invasive cancer. And so the positive predictive value rises a bit, but the sensitivity goes down quite precipitously. So they did this kind of interesting thing where they looked at pairs of pathologists. So if you have 11 pathologists, there's 55 potential pathologist pairs, and they could, for each pathologist pair, decide if in any given tumor there was a tumor in the core biopsy or not. And so you can create 55 of these plots to decide what your positive predictive value and sensitivity is. So that was a challenge, but we get good numbers overall. We were predictive, but certainly nowhere near 100% predictive. And certainly we missed patients who we thought, or we were sure had core biopsy, a tumor on the 12-week core biopsy, but did not have tumor on the resection. Of course, this group of patients received more chemotherapy in the interim. So the good thing now is that this is still being done, but it's being evaluated in real time. So we're no longer sending the tissue to UCSF. When a patient here at the U is on I-SPY, at 12 weeks, they get their MRI and they get a core biopsy, and the core biopsy is handled as a clinical case. And it's all formalin fixed, paraffin embedded. It's, you know, beautifully embedded. You can get recuts, you can get immunostains, you can get whatever you want. And you're going to make a qualified assessment of whether there's invasive carcinoma in that core biopsy or not. And the patients who have favorable MRI findings and have no invasive carcinoma in the 12-week specimen, they are offered to bypass the adriamycin cyclophosphamide and go straight to resection. So they get about 3 months off of their chemotherapy course. So this is the initial data as of September of this year of the patients who have had this biopsy, this type of biopsy done in a clinical setting and been evaluated for stopping chemotherapy early. And so it's kind of interesting. So the legend is maybe a little bit confusing. MET and SKIP means they met the criteria and they skipped the adriamycin cyclophosphamide. And then if that happened, then what was left in their breast after they had their resection, breast and lymph nodes. And so those are the green bars. And so they all had either RCB 0 or RCB 1. 85% of them were RCB 0. But interestingly, there were a significant amount of patients that met criteria and for whatever reason chose not to skip the adriamycin cyclophosphamide. So they got the full course of chemotherapy and then got a resection. Still, some of those, you know, if one patient had a residual tumor, a low RCB, but an RCB nonetheless of non-zero. Some patients certainly didn't meet criteria and did not skip. So those are the red bars. And you can see there's kind of an even distribution of quite a bit of residual tumor and none. There's some that we missed or that we thought had residual disease. They probably did have residual disease at 12 weeks, but after the AC, they did not. And so you just have a mixture. And actually some didn't meet criteria, but still did not get their AC. And interestingly, some of those had an RCB 0. So they must have had a very small amount of tumor in that core biopsy, and maybe that core biopsy removed any residual tumor. So I think the goals for us going forward is to decide if truly every patient with a path CR has the same prognosis, because that is the dogma, is that if you got a path CR, you're good. That's a very good indicator of improved survival. But I would say that, you know, the initial studies about this really, first of all, they showed the strongest association in patients that were HER2 positive, hormone receptor negative, or triple negative, and not so much in the hormone receptor positive patients. And also, these patients received kind of conventional cytotoxic chemotherapy. This one study at MD Anderson looked at all of their patients with a path CR, no matter what they got. And their recurrence-free survival at 7 years was the same regardless of the tumor type and regardless of the chemotherapy regimen. But this was quite a mixed bag. They got different regimens. They got certainly different durations. You might wonder why somebody got more than 7 months, probably had some interruption in care, et cetera. So this is hopeful. This supports like, okay, whatever got you there is good. You're good to go. But I think that things to think about for I-SPY too is that by design, the study has a lot of novel therapies like the antibody drug conjugates, PARP inhibitors, checkpoint inhibitors. And I don't think we have that good of a hold about understanding about how those affect tumors and what a pathologic complete response looks like in those patients and what that will mean down the line. So I think what we're doing is great. And I look forward to analyzing these specimens prospectively, these inter-regimen biopsies prospectively, and the and certainly resection specimens, and correlating the long-term survival in these patients that have a past CR and those that don't. We have many. I'm going to stop there here in a second, but just to say that the pathologist working group has many other projects that we're working on. It's a very active group. Besides this 12-week biopsy, we have several other biopsy manuscripts that have been submitted or are in process. And we meet once a month, and it's quite stimulating. I would like to acknowledge, first of all, Dr. Emil Richilla, who covers breast service when I'm not on service. He's covering me today. And he's just a joy to work with. Similarly, Kimmy Raby, who worked a little bit with the I-SPY working group when she was a fellow, and now, of course, is covering breast service for us and doing an excellent job. Doug Yee, who's a Masonic Cancer Center director and is on the executive committee of I-SPY. And then there's a bunch of pathologists in the pathologist working group, including Jody Carter, who's working on this 12-week trial with me, along with Sarah Venters and Sanal Shad. So thank you. I know I cut it a little long there, but I'd be happy to answer any questions.
Holly Leo here, just a comment. What a tour de force. Just a brilliant presentation on such an important problem. And I hope, and I'm sure it gave people in the department who don't look through microscopes an appreciation of how hard everybody in AP, and you in particular in this I-SPY study, do things. I mean,
thank you.
I know every case is different, but how long might you spend, or what sort of, average on a case? Because it seems so involved for these trials, and it's so important. It's not something you put through like a derm path slide and just read it in a minute and it's gone. So I don't know if that's a fair question.
No, well, I'll be happy to whine about how long it takes me to do these cases. Because it does take a long time, and the charge, is the same. The charge of a lumpectomy is the same as a hysterectomy for no tumor, basically. So it's quite, it takes a long time because there's a lot. When you don't have a grossly evident tumor and you're trying to create this 3D image from many, many two-dimensional slides, it is a lot of work. And just takes practice, but I'm kind of ashamed to say how long it takes me to sign out one of these cases. Certainly if there's no tumor, that's awesome. It's awesome for the patient especially, but it's awesome for us too. But yeah, if they have significant residual tumor, it's a lot of work.
Just to add to that, Leo, I don't think Molly finished answering your question. All it takes is one interruption in the middle of looking at the case, and you are back to starting all over again. So it's very difficult to really measure how much this case take. But
Sure.
Dr. Yee has a question.
Hi, Dr. Yee.
Yeah. Hi. If I could make a comment, Molly was very modest in that presentation. I would just want to comment on the I-SPY standards of the 11 pathologists that looked at this. Molly was the most accurate in determining past CR on the 12-week core biopsy. So she has become the gold standard for the entire cooperative group network because this is a critically important aspect of where we're trying to go with I-SPY. And I think Molly was actually completely right. Is any past CR by any drug the same? I think most of the data suggests it is, but the medical oncology world is just a tiny bit skeptical that may not be true. So we need to just make sure that if you get, let's just suppose you get a complete pathologic response to an immune-based therapy, is that just as good as a complete pathologic response to conventional cytotoxics? And I think we're probably in the era of a change in the way we think about systemic therapy for all cancers. But hopefully we'll prove that, and Molly's been incredibly important to our efforts within I-SPY.
Hey, Molly, this is Andy Nelson, and Doug probably you might have some comments on this too, but one of my thoughts on that exact thing that you were bringing up, Doug, with which, going back to Molly's comment, which is all pathologic complete responses may not be created equal. What's the status within I-SPY of looking at some of either the serum, serum biomarkers, whether they be circulating serum factors that we can do by mass spec or clinical chemistry, versus circulating tumor cells, versus kind of the concepts, particularly in the ER positive cases, where even if there is an apparent path complete response, we're worried about, dormancy and bone marrow resident metastatic cells and things like that. Any insights into some of those corollary biomarkers that we might be able to layer on top of what Molly's doing with the primary tissue?
Molly, I don't know if you want me to comment, but
sure.
Cell-free DNA is running out. It will be in the next amendment.
So
all patients are going to have cell-free DNA collected to see if, kind of like a little bit like our colleagues in hematologic malignancy, whether or not there's a molecular residual disease kind of component. And so that's going to be part of the trial. I don't know how we're going to use it. We're going to start to collect it. So somebody has the MRI pass CR as well as the biopsy pass CR, but still has cell-free DNA. We're not quite sure how to manage that at the moment, but we are collecting.
And Molly, I'm just wondering, is there anything like from all of the hours you spent staring at these tissues, I mean, anything about the stromal response, anything about the immune cell infiltrates in these path CRs where you get a hunch that there could be something about the residual microenvironment that could be telling as well?
Yeah, I wish I could say that I have great insight on the topic. I don't. I mean, there are some studies that suggest that if you have a lot of tumor infiltrating lymphocytes at resection, that is a good prognostic sign. Those are very early days. I have to say that I do want, you wonder, just some patients have zero, seems like no response. Some people have just a dramatic response. And the checkpoint inhibitors are ones that will just surprise you, right? That you'll just see the rare ER positive tumor that has a path CR. A lot of those are checkpoint inhibitors. Okay. But they don't tend to have like a ton of TILs, tumor infiltrating lymphocytes, in my kind of limited experience with that. I think we are going to have to kind of go back and just make sure we're collecting the appropriate data for that. With these novel agents, I just can't imagine that it's the same as the cytotoxic chemotherapy.
Yeah, well, I mean, big plug. I think that is, if we keep moving the department forward on a whole for spatial analysis and can use FFPE for these things, there's some ideas I think we can develop.
Yeah, absolutely. And there are individual, a lot of the individual agents they've done, targets. So for the PARP inhibitors, they've done like, let's look at additional markers in these patients. Why did some of these patients respond to PARP inhibitors where you wouldn't, the kind of the BRCA-ness of their tumors, et cetera.
Yeah. So
they've done a lot of additional molecular testing on specific tumor types and significant on specific treatment types. So there's room for all of that.
Cool. Thanks, Molly. Appreciate it.
Well, thank you for your attention.